Hey team, welcome back to another episode of the Student Paramedic Podcast. Hey team, welcome to another episode of the Student Paramedic Podcast. If you're new, my name's Alex and I'm your host today. And today I'm sitting down and having a discussion with Sandra Garner, who is a psychologist who works at Queensland Ambulance Service and does a lot of work in the mental health space for the service, in particular creating the mental health response unit and a few other programs as well. So mental health presentations and calls are increasing in the pre-hospital environment. So we're going to discuss today how to improve and create safe care for patients experiencing a mental health crisis in the pre-hospital environment. So thank you, Sandra. Thank you for coming on, having a chat and sharing your knowledge.
Thanks, Alex. It's a really exciting opportunity to do this. And I feel really privileged to be talking to you and to up-and-coming paramedics as well.
I gave you just a brief introduction, but is there anything that you'd like to introduce a bit further about yourself?
Yeah, thanks. So, I'm a psychologist and I've worked for about 25 years in all sorts of areas of mental health. So I've worked in hospitals, in inpatient units, emergency departments. I've also done some research, worked in prisons, worked in the non-government sector, some private practice, and in some service planning. So I've done a broad range of things in the mental health space. And I started here at the QAS nearly 3 years ago now, and I was brought on board because the QAS realised that mental health jobs were increasing exponentially year on year, and that they were becoming quite complex for paramedics on scene to be able to assess people who've got mental health needs, because often it's in a very grey area of kind of healthcare delivery. So my job was created by the Office of the Medical Director to sort of direct the mental health response program. And it started at about the same time that some national research was done by the Movember Foundation and Turning Point, which surveyed first responders and paramedics. And it exemplified, or it really highlighted, that paramedics felt that they didn't have the skills, knowledge and confidence to deal with people who are experiencing a mental health crisis. And so the QAS, took that research, had a look at the types of jobs that were going, and really took a chance to do a few things a bit differently. And so it was really, I guess, brave of the QAS to say, we're not just going to educate 4,500 paramedics in Queensland to be mental health clinicians. We're going to try something new. So in 2019, we piloted a couple of things. One was putting mental health clinicians into our 000 Operations Centre, so to provide information, advice, support and assistance to paramedics on the road and to emergency medical dispatches as well. And we also piloted co-responders, which was a mental health clinician from a hospital working with the paramedic on road to respond as a first response to people who were experiencing a mental health crisis. So both pilots were incredibly successful, and to date now they just have become part of business as usual for how the Queensland Ambulance Service operates. And and have become really pivotal and integral in how we deal with people in that mental health crisis space.
Yeah, absolutely. And that was something before you mentioned off air, was that, 1 in 8 calls in QAS, so 000 now mental health related, which is a significant amount. And talking to a lot of students, they agree, or it's that sort of same, understanding that they don't feel very prepared to sort of assess and appropriately sort of treat and help people who are having a mental health crisis. So it's really incredible that you guys are doing all this. It's pretty exciting to see that change in the service. So what are some of the most common mental health crises or presentations that you see in that pre-hospital environment?
So that's It's a really good question, and it really is what we see that comes through, especially in Queensland. We use MPDS, so we use the as a dispatching code, so they get identified as those jobs. So mental health jobs are really a broad range of crises where a person feels that that either themselves or somebody they know or care for or somebody that they've observed is behaving in a way which is uncharacteristic, or that is perhaps at risk to themselves or to other people, or perhaps is aberrant in some other way. So this is not necessarily what a hospital would define as a mental illness, but it is a broad range of behaviours which are I guess, unusual or abnormal, for want of a better word, or out of the realm of what would be a normal response to a situation. So that can be anything, and it's very different. And I guess a mental health crisis in this space is as heterogeneous as, every single person, because everybody has their different levels of resilience, their different abilities to cope. And so we might see somebody who's experiencing a mental health crisis, that in response to, say, for instance, the death of a pet, whereas somebody else might be able to take that in their stride. Everybody's different. Everybody has different coping mechanisms, resilience, resources to be able to deal with those types of situations. So it is different for everybody. But I guess the main or the most common types of mental health crisis that we see, and we know that it's about, across the state of Queensland, about 100 calls a day, are for people experiencing suicide crisis. So this includes people who are experiencing thoughts of ending their own life, people who are planning to take their own life, or people who have attempted to end their own life through suicide. So, that's about 100 calls a day for people. And I guess that a suicide crisis is probably the pinnacle of somebody experiencing poor mental health, or is, the ultimate in a mental health crisis. And we get called for those people from other healthcare providers. So Lifeline will call and say, we've got somebody who's acutely suicidal on the phone. Beyond Blue, other kind of helping professionals, GPs, psychologists. We might get a call from a third-party caller who says, I've just received a text message from somebody I know and care about who says that they're planning to take their own life or are attempting to take their own life. And less often, but it still does happen, by first parties, by people who call themselves and say that they are experiencing a suicide crisis. So I think that is probably the biggest call for mental health, is people who experience that. And I guess that is a massive challenge. It's a massive challenge for health services in general. The suicide crisis is, a challenge for the QAS, for paramedics, and for healthcare professionals, because it involves being able to assess a bunch of risk factors, so assess what's happening for that person. So we need to be able to engage with that person. We need to be able to find out what's happening. We need to get a bit of a story. We need some collateral information, and we need to have a really clear understanding of what's happening for that person. And sometimes in a crisis situation, that's not always possible, or sometimes there are some barriers to be able to get all of that information, and that could be acute distress or agitation, or physical barriers in terms of we need to be able to find this person or locate this person. So it does pose that considerable challenge for first responders, for people who are in that mental health crisis space.
Yeah, that makes a lot of sense, and that's a really good point, and really actually found great value out of what you said at the start, particularly in terms of basically what constitutes a mental illness in the pre-hospital environment may not necessarily be something that, a hospital will determine as a mental illness, but, the abnormal behaviours or something uncharacteristic is really, really interesting. And I guess that sort of has changed my perspective on that a little bit as well. So you mentioned there about assessing and some of the barriers to assessing. So what is a great sort of approach or I guess, sort of system in terms of assessing a patient who is either suicidal or is going through a mental health crisis?
I think this is the challenge of mental health for first responders as well, in that unlike other crises, so delivering a baby or a cardiac arrest, there is no algorithm. There is no piece of A4 paper that you can put out and put all your bits of equipment. There is no little bag that you go to at the back of the truck and go, all right, this is what I'm going to do here. And it's the same for everybody. So I think that the first thing to really acknowledge when approaching somebody who's experiencing a mental health crisis is, and this was something that was a surprise to me. So I'm a psychologist. I've trained for a really long time. I've got my toolkit is full of therapies and engagement strategies, which all have very complex acronyms. And, you know, I really pride myself on all of the training that I've done. But when we have a look at what is evidence-based best practice for a person who's experiencing especially a suicide crisis, but any kind of mental health crisis, the only evidence base is engagement, is contact, is somebody being interested in what is happening for this person at that time. And so it's that's something that anybody can do. And it's really important to keep that in mind, is that somebody who's experiencing a mental health crisis doesn't necessarily need to see a psychologist or a social worker or a mental health practitioner. Anybody can engage with somebody who's experiencing a mental health crisis and make that connection. And that's what's important for the person who's experiencing that crisis. And sometimes for some people, it can be that, oh my goodness, I don't know what to do here. I don't have an algorithm. I don't have a little pack that I've pulled out of the back of the car. It's having to go in and you know, assess a situation based on information that you can glean from the scene. And that is, it can be a challenge, and in some circumstances it can be a challenge. But I think that if we go in with that general principle as well, that I have what this person needs, and that is some kind of human connectedness. And there's a few elements to that. And the first is approaching the scene with what a psychologist would call unconditional positive regard. But what it means essentially at the end of the day is just going in with a non-judgmental attitude. So we're going to go in, and perhaps it's somebody who has done something to engage in deliberate self-harm, or perhaps it is somebody who's having a panic attack about something that isn't necessarily something that would, you know, be on the significant life event scale. But by going in and realizing that this person is having a particularly bad time, they're having a particularly bad day because they don't feel that they have the resources and the resilience and the skills to be able to deal with the problems that are in front of them. So going in with that non-judgmental attitude is really helpful. That's the first thing to do. So it's about that, that making sure that we are treating each patient like, that this is the worst day of their life that they're having. They wouldn't have called 000 if they weren't in that situation. So that's a really good way to approach the situation. The second thing, and research, you know, says that the second element is empathy. And sometimes empathy can be tricky. Sometimes empathy can be, if you think about it too much, is it empathy? Is it sympathy? Is it walking beside? Is it walking, say, is it in their shoes? Is it not in their... Sometimes you can get stuck in that I need to do this empathy and it needs to be fantastic. The thing about empathy is it's about being interested in somebody. It's about being interested in what's happening for them. And we show empathy and we show that we're interested in what a person says by just asking questions. I sort of, my mantra is as well, if you can't be empathetic, be interested in what's happening for this person. And that's always the second key, is about being interested. So to be interested, we just ask lots of questions. What's happening here? What's going on? What happened before he got here? You know, what's worked? What hasn't worked? Asking a whole bunch of questions, being interested in that, in what's happening for that person, is the essence of empathy. but it is also then making that human connection, which we know is what the evidence base is in this situation. So the second element is always being interested in what the person has to say. And then the third element is active listening. And active listening is really important for various reasons. And active listening is, again, a very complex, and we could do a whole podcast on active listening, and it's not necessarily something that is brain surgery, but it does require a few things to happen. So the first thing, the first element of active listening is actually hearing what the person says. And so the first, it's a bit ironic that the first step of active listening is actually listening, but it is giving them the opportunity to answer your questions, to find out what's going on. And so the second element of active listening then is being interested in what the person says and understanding what's going on for them. And if you don't understand what's going on, asking more questions. How did you end up like this? What have you done to hurt yourself? How many tablets have you taken? Being interested in what the person says. So, and so we want to understand what's happening for that person as well. But it's also really important as well to remember what people have said. And especially when I talk about active listening and remembering to people on the telephone or people in a who are first responders as well, sometimes the first thing that comes out of somebody's mouth is the most important thing. And especially if somebody has, waited a while to call 000, or they've waited a long time to call for an ambulance, they've got something real, they're building up a story in their mind, and they need an opportunity to get that out. And so by taking the time and listening, engaging with what the person is understanding and remembering their story to then ask them more questions is a really important part of that engagement process. And that's the human connection that will work for somebody who's in a mental health crisis. So it is just about getting the story. And sometimes it can be a bit intimidating, or it can be a bit difficult. But I think it's also really important to have that kind of genuineness. And so I think for a paramedic, there are a couple of things on your side. One is the uniform that comes with a whole bunch of respect, and it comes with a whole bunch of kind of relief that you can come. So if you think about who's experiencing a mental health crisis, so they're having the worst day of their life, they are probably in some kind of fight or flight, or in some kind of heightened state, and are also feeling completely overwhelmed, like or a bit hopeless or a bit distressed. And having the paramedic come is like a relief. And it is, here it is, it's somebody who can help me in this situation. And that's the way that a paramedic is perceived, is, oh my goodness, here it is. I felt out of control, and a paramedic's going to come in and take control of the situation. And sometimes paramedics can walk into the situation and feel immediately that hopelessness, helplessness, distress that the person is feeling. But actually, what they are there for is to, be that hope, be that human connection, be that I can help you in this, what seems like a pretty dire situation. And sometimes it is about going with what you know as a paramedic. So if what you know is, the ABC of an assessment that you do for a person, say that. And that's what you're going to open with. Look, I can see that things are not going well for you today. Hey, do you mind if I take a set of observations and we'll see what we can do? Sometimes by doing that as well, it's really eliciting that kind of confidence, and it's also establishing that kind of relationship that's really important. And as well, it's reinforcing to the paramedic that, look, I'll just start with what I know. I know blood pressure. I know taking sets of observations. And then that will start, if we then start to look at our principles of active listening as well, we'll then launch off into being able to find out what's happening for that person. And somebody who's feeling out of control, somebody who's feeling hopeless or helpless, to say things like, hey, well, your blood pressure looks good, or, all the vital signs are looking really well, that's really positive. That can be something that can be quite grounding for a person who's experiencing distress.
Those are some really great points. And I think it's like just the way in which you're approaching patients in that sort of perspective with, those three focuses is really quite profound, in the sense that a lot of the questions that have come from students is like, what if I say something wrong? Or how do I make sure that I'm being caring and not perceived as being, overpowering, or pretty much, not doing the right thing in that sort of sense, or saying the right thing. So I think, just being human, and it comes back to those really important things like communication and listening and just being empathetic, and all of that's really, really quite just part of what it means to be a paramedic, I guess. So if you go back to those principles, it seems like that approach can be really positive and give patients a really positive sort of experience with you. And I guess that's something that's come up quite a lot throughout the podcast with different people, is pretty much the way in which you engage with patients. And if you make the experience positive for them, the more likely they are going to want to engage with healthcare in the future and have more of a positive experience. So I really love those. I think those are really great. So going from that, I guess then, so we've gone from how do we approach a patient who is experiencing a mental health crisis. I guess the thing that will stem from that is the people that aren't necessarily going to be non-judgmental or empathetic. I think most students who have been on a placement or new grads have experienced situations where colleagues or mentors are sort of stigmatizing patients that are experiencing a mental health crisis. And so I just wanted to go through with you, like, how do we navigate that when we want to be as empathetic and non-judgmental and as listening as we can be? How do we navigate those situations?
I think, it is incredibly prolific, stigma, and stigma is still a major part of the delivery of mental health services, and stigma happens on many levels as well. What is really important to think about as well is some of our preconceived ideas that we have about mental illness, mental health crisis, and so sometimes a lot of the stigma from health professionals, and I've worked with lots of health professionals as well who've said, like, it's too hard, it's too difficult, I don't understand, I don't want to say the wrong thing, I don't want to be the person who pushes the person over the edge. And I think that some of those fears come from perhaps negative experiences in the past. But I also think that is coupled with the fact that there is systemic stigma that happens within the health system as well. And we know that that mental health patients in emergency departments, voluntary patients will wait inordinate amounts of time to be seen in emergency departments, anywhere over up to 11 hours. They're waiting extraordinary amounts of time for mental health beds. And oftentimes people have had a bad experience with the health system as well. So sometimes people who are experiencing a mental health crisis as well will be a bit resistant and a bit resilient, resistant, because their experience with the healthcare system has not necessarily been a positive one. So, and by that I mean that perhaps they've called 000 in an emergency, and the police have arrived when they've been expecting an ambulance. Perhaps they've called 000 for a medical emergency, and because they've had a history of mental illness, the police have arrived or with the ambulance and been heavy-handed. Perhaps time hasn't been taken to understand what is happening for that person as well, and there hasn't been enough time taken to listen to what some of their resistance is to going to the hospital, and perhaps it's turned into the need to use force or to use chemical restraint. So those previous experiences are what is going to be meaning that that everybody in the mental health, in responding to that mental health crisis is going to be I guess, on edge, for want of a better word. I don't know if that's the right thing to do, but feeling like, this could have a really negative outcome. But again, if we go back to our core principles, and even the Queensland Police are spending a lot of time in training officers in that de-escalating scenes and de-escalating situations. And I think that that it is about taking time. So taking the time to find out what's happening, trying not to rush a scene, trying not to rush an assessment, trying to take the time to find out what's happening for a person. But also arming yourself with as much information as you can before you get to a scene. So being able to know what to expect. So I think that some of that stigmatization and some of that negativity can come from that unknownness. And so at the QAS, so this isn't everywhere, but we have the liaison clinicians with Student Operations Centre. And so if it is a mental health job, you can call via the consult line to the mental health clinicians. They can have a look at the Queensland Health Mental Health database. They can give you a bunch of information about this person. They can give you a bunch of information about their history, what you might what you could possibly expect on scene. Last time there was an emergency, what did it look like? And I think if we go there armed with that type of collateral information, it can help to reduce some of that anxiety that we feel as well. So I think with that kind of interest and that empathy for a person as well, and if you're going to scene thinking about what it is that this person is likely to be experiencing, and thinking about this person as a human being, like we also know the stats on mental health is that we've got a 50% lifetime prevalence rate. So that means that person experiencing a mental health crisis, if it's not me, it's you. If it's not you, it's your brother. So we need to make sure that we're keeping in mind that this is a really human response to a situation. That's a very long answer to your questions about stigma and about what we do in our approach. But I think if we think about who is this person, a person who's experiencing a mental health crisis didn't wake up today going, this is what my day is going to be. And a person who, even a frequent presenter, wasn't born that way. They are somebody who experiences even frequent mental health crisis or a mental health crisis is somebody who doesn't have the resilience, the skills, the strategies and the resources to be able to deal with the problem that they're facing at that particular time. And so we need to be part of that solution rather than part of that problem. And so it is really important if we do come across negative attitudes either with our peers that we work with or even when we go to the health system, I think it is really important to advocate for the patient. So if you're in Queensland saying things like, I think what we need to do is find out some more information about this patient. So if you do find yourself in a situation where people are using derogatory language or perhaps being quite discriminatory or stigmatising of a person before you even get to a scene, calling the mental health clinicians and saying, let's have a chat to them. Let's find out a little bit more about this person before we go there. Let's find out some of the reasons that they might be behaving this way. Advocating for the patient, advocating for that kind of more empathetic approach and that non-judgmental approach. And I think that that even a new grade paramedic or a student can do some really simple things like not engage in the use of derogatory language, not engage in negative connotations about any patient. And so just not buying into that part of the conversation, and that will role model to the person that you see, even if it is a really experienced practitioner, that I don't want to have this type of conversation. I'd like to have a different type of conversation. I'd like to find out a little bit more about what's happening for this person. And I think that if you approach a scene and understand a little bit more about what's happening for a person, it will be much easier to be non-judgmental, be interested in what's happening for the person, and be interested in engaging in that active listening to help them through what they're going through at that time.
That's some great strategy in terms of dealing with, situations where you may feel uncomfortable in terms of what's being said about your patients, whether that be a patient who is having a mental health crisis or any patient, as you said. But I really loved when you were talking about that. I was really thinking like, wow, students can be, the role model. They can lead by example, even if it is, not engaging in it, or just having something that's a consistent theme with quite a lot of people that we talk to is curiosity. So like, why is that person calling? We use the example of, why did the patient call for, their stub toe, whatever it may be. And it could be the fact that something else is really going on. And sometimes it might not be, but sometimes there could be something else going on. So I think that curiosity and just trying to lead by examples are really, really important part of creating change and trying to be the best clinician that you can be, whether that be a student or a new grad or whoever. So I really love those points. They're really great. You mentioned in there as well, so de-escalation, and that's something that's quite a common question is how do we de-escalate a scene?
Some of those acute situations might be things like people who are having a suicide attempt in progress. So you might come across somebody who is, attempting to end their own life. You might come across somebody who's acutely intoxicated, or somebody whose behaviour is completely out of control. So I guess there are a few steps to go through as well. One is to be as safe as possible, of course. There is no expectation that that paramedics should go into a situation which is going to be unsafe. I would never expect you to jump over the cliff to get the person who's jumping off and things like that. So of course it's about being safe, but it's also about making the scene as safe as you possibly can as well. And so there's a few things that you can do as well. So arming yourself with as much information as you possibly can is probably a good strategy to start off with. So knowing to what you're going to. And I guess, again, to harp back onto the liaison clinicians back in the operations centre, they'll be able to provide you with a whole bunch of information. Look, this is a gentleman who, when he takes drugs or when he doesn't come out of his room, can experience auditory hallucinations. So knowing what you're going to go when you get there. So being a bit prepared. So and also thinking, so am I going to need to change my communication style with somebody who's experiencing auditory hallucinations? Am I going to have to, ask questions a whole lot slower? Am I going to have to take things a whole lot slower? Am I going to need to be able to, extract this information in a different way? So just having a think about it and understanding the scene that you're going to straight away. So some really general points about de-escalation in general is one, to remain calm yourself. And so you know this, there's very practical things, but just like running into or going into a trauma, you're not going to run to get there. You're not going to sort of barge in the door. You're not going to do all of those things as well. So you want to go arm yourself with this much information. So what you want to do as well is assess the scene. Is there somebody else on scene who can give you some information? So if you're going to someone's house, say for instance for their son who's experiencing hallucinations or who won't come out of their room, getting some collateral information from mum and asking some questions like, what's going on? What do you need at this time? What do I need to know about the patient? Or what do I need to know about what's going on? Asking those questions first and building up a bit of a scene and understanding what's happening for the person. Then it's about, I guess, making the scene as safe as possible for yourself. So it might be saying to the person, can you come and speak to me out here in the lounge room? Do you mind, if we go out to the mailbox and have a chat? Do you, want to come outside? So making that scene as safe as possible. And then it's going back to your big four, your unconditional positive regard. So you're non-judgmental, you're being interested in what the person says, you're active listening, and finding out what's going on and asking some questions about what's going on, what would be helpful, what's not helpful. You also want to be able to ask them what it is that they need, especially somebody that's incredibly heightened. ask them what do you need right now? What would be good? And by empowering them to be able to, take a little bit of control of the situation, because we have to remember that a mental health crisis is where somebody feels hopeless, helpless, out of control. So by asking the question, what would be helpful? And you might be surprised about what that answer is. It would be really helpful if I could get a drink of water, if I could have a cigarette, if I could put my shoes on, if I could take my shoes off, whatever it is. And then, putting in place some reasonable things to make sure that can happen, or that you're making the person feel as comfortable and as safe as you can. You're there to advocate for the best needs of the patient, and the best needs of the patient are sometimes not what we think are going to be what it is. So we need to ask the question. We need to be interested in what the person thinks would be helpful at this time. And then it is about extracting as much information as you possibly can from that person in the safest possible way. And so we want to get a pretty clear picture of what's going on for that person at that particular time. Then we also want to make sure, and it's almost not a negotiation, but being able to give a little and take a little. So if you want to have a cigarette, look, I'm happy to wait while you have a cigarette. And then are you happy to get in the ambulance, or what can we do? Or if somebody is, particularly agitated, it might be that instead of saying to them, calm down or sit down or do those things, it might be, can you walk over here? Can you come over to here? I'm going to do something. So working with what you've got. So instead of, if you can tell that a person is very agitated in their pacing. So, do you mind if I walk beside you? Do you mind if I stand over here? And do you mind just pacing on the corridor so that I can still talk to you while we do these things? So we're not really, instructing a person. We're not trying to force them to do something that they don't want to do. We're kind of working with them. And that way we're kind of establishing that, we're here to work for you. Because again, if we try to think about why people are heightened, why they're escalated, and we know that people are in a mental health crisis because they feel hopeless, helpless, out of control. But also what we want to do is to advocate for that person and advocate that we're there to help them and we're there to keep them safe. And we also want to be able to, take the time to understand what it is that they need. And if we start to also think about why that person has got to that situation that they're in, we also need to keep in mind as well some concepts like all behaviour is trying to communicate something, and sometimes people can't articulate what's going on. So perhaps somebody is acting in a particular way or behaving in a particular way to get across a certain message. So if somebody is yelling and screaming, perhaps they feel like they're not being heard. If somebody is pacing up and down, perhaps they feel like that they feel, that there's something going on that they can't control, but they can control this. So we want to work with that as well. And once we establish that, look, I respect if you want to pace up and down there, that's okay, then they will feel a lot more comfortable to de-escalate with you and to be able to talk to you, because you're not, giving, orders or making people do something which perhaps that they don't feel comfortable to do, or makes them feel even more hopeless, helpless, out of control. Does that make sense?
Yeah, it definitely does. And that's really interesting. I really love how you just said, all sort of behavior or is a way of sort of communicating something. So that's really interesting. No, I really love that. And equally as well, putting the control back in other people, that person's hands. And think, because like we come from a very sort of paternalistic sort of approach where we're like, we know what's best. We got to do, that certain thing. So I think it's really important to sort of challenge that sort of notion as well. But no, it definitely makes sense. And hopefully those sort of points will help us sort of de-escalate scenes in the future. So I don't want to take up too much of your time. So I'll go on to the last couple of questions. So basically, from your perspective and your insight, what do you think are some of the best ways students and grads can start to prepare themselves, whether that be through resources or communicating with people who are psychologists and things like that, on how to best improve their approach and patient care for those mental health sort of presentations?
A really good question. And I think that there's some things that you don't need to do, and that is things like, read the DSM and understand every diagnostic category for every mental illness that there possibly is, because it's not a precise science. I could sit down with, a social worker, a psychiatrist, another psychologist, and see the same person and come up with 15 different diagnoses. Like it's not precise. And I think that, so not to get too bogged down, to have an understanding of the different types of disorders and diagnoses is important, but focusing on that and focusing on making a diagnosis on the side of the road is definitely not what a paramedic needs to do, and is actually probably not helpful for the patient. I think practicing those sort of active listening skills and the those kind of engagement and how you can sort of talk to people and how you can extract information from people using that kind of curiosity, using active listening skills, using that kind of I'm interested in what you're saying in your conversations with your family and your friends and doing things is probably the biggest thing that you can do, which will get you into some really great communication habits and really understanding that and honing some of those skills, I think, is probably something that could be quite easily achieved by a paramedic and a paramedic student. I think that it is probably important as well to understand about some of the kind of sociological kind of impacts of mental health. I think that we also need to acknowledge that at the moment, during the sort of uncertainty of COVID, that we have the perfect storm for mental health and mental health crisis, and that it's going to look different. Yeah, just keep in mind that a mental health assessment is very different to what an assessment of a person who's, say, in a trauma or who's having a medical event looks like as well. And to often go with what you know. Go with what you start with. So think about, is there a biological basis for this behaviour first of all? You want to assess for, making sure that there's no, urinary tract infection or impacts of drugs and alcohol or something else going on. So you know that, and so assess for that. Ask some questions about that. And people will be are really in tune to their bodies and are doing it, and that's really mirroring that human connectedness, in that people like to talk about themselves and want to talk about themselves when they're experiencing any type of emergency. So asking those types of questions, but also again then using those skills and having a look at not only what's being said, but how it's being said, and making sure that there's a congruence between what you're hearing and what you're seeing. And if you have an incongruence between what you're hearing and what you're seeing, ask some questions about that. So if somebody can say, oh, everything's feeling fine, but their blood pressure is really high, you might like to ask some questions about that. And again, be interested, remember what's going on for that person, and then you've got a launch pad to ask a whole bunch more different questions. It's also really important as well to take notice of what's happening around the environment as well. And that's quite easy for a paramedic to do because they're very good at situational assessment, situational risk assessment. So sometimes it can be about asking questions about, things that are around them as well. So using the types of sort of stimuli or types of those environmental cues can be really good in terms of launching into a conversation. And again, it might be about practicing that with the people that you know, with family and friends, about being interested in what someone's wearing or somebody's new shoes, might then be able to launch into a much bigger conversation about something else that's worrying that person.
That's great. There's some really great points that hopefully all students and new grads and everyone will take on board. I know it's like I'll definitely be taking on board for the future. So thank you so much. I feel like I've learnt a great deal today in terms of, changing my approach to helping those who are having a mental health crisis. So thank you so much for sharing all of your insight today, Sandra. I really appreciate it.
All good. No, thank you very much.
Thanks for listening to this episode of the Student Paramedic Podcast. You can connect with us on Instagram, Facebook, Twitter, or you can email us at thestudentparamedicpodcast@gmail.com.